He had been the president of Indian Psychiatric Society from 2015 to 16. He is the deputy editor of Indian Journal of Psychiatry. He is president of so many organizations at present: Indian Association of Geriatric Mental Health, president of Indian Association of Private Psychiatry. He is the president of Society for Bipolar Disorders of India. He is the president of Indian Association of Biological Psychiatry. He is the president-elect of Asian Federation of Psychiatric Association, that is AFPA. And he is a very good orator, and we will be listening to his remarks on this topic. Welcome, Prasad. Welcome. With this, I hand over this session to be carried over further by Dr. Prasad, by Dr. Dalal and Dr. Prasad Rao. Welcome, Chairperson, sir. It is yours. Please now.
Thank you, sir. And I welcome all the dignitaries, especially Dr. Prasad Rao Garu and the other office bearers, Dr. Tufan Pati, Dr. Amrit and Dr. Alim, who are, I would say, the brain behind this Thursday musings. And they have started with psychotherapies. And we all know that psychotherapy is so very important in our, I would say, teaching, training, and after that practice in psychiatry. And this is the, I would say, course which must be very much sought after, because generally nowadays the thinking is that everybody is a biological psychiatrist, or they write themselves as neuropsychiatrist. And in that probably rat race, we are somewhat losing the healing touch which comes through psychotherapy, where we try to treat not the disease but the person. So with that, today's topic is trauma and psychotherapy. So this is so very important in the current scenario as well, in the case of COVID pandemic. And then there are so many other, I would say, traumatic situations, disasters, which keep on happening around our country and will keep on happening in times to come. So this therapy is of immense importance. And I think the orator, Dr. Sukanya Ray, will do the justice in this, I would say, webinar, where all these things will be dealt with. And I would now request Prasad Rao Garu to do the needful. Sir.
Good evening. It's really my very, very pleasurable moments. For me, psychiatry is psychotherapy. The beauty of psychiatry is the art of psychiatry in the form we deliver the therapy. And today we have a brilliant scholar, Sukanya Ray. Before that, I would like to say that the brain behind this program and the title given, The Musings, is wonderful. I congratulate both Amrut and Ali, my dear friends. They are my inspirers. And of course, Tufan Pati, my elder brother, for giving me the opportunity. Sukanya Ray is Baulabashi from Bengal. Pardon me because I know little of Bengali, so I'm using that. She is a brilliant, she had a brilliant career. She finished her MSc and then finished her MPhil from NIMANS. For the last 15 years has been in active therapist. And I really loved her CV for many a reason. First of all, right now she is an assistant professor in the School of Human Ecology in the most sought after institute of this country, Tata Institute of Social Science. And I loved that she is the principal investigator in the research project of COVID-19, one of the multi-centered research And I wish her all the best so that she can give us the insights, true insights, as this project unfolds. She has been practicing psychotherapy for the last more than 15 years, I would say. She's an honorable member of the American Psychological Association, has been training students, has been reviewing in the most important journals of psychology and psychiatry. Practicing, as I can see, eclectic but multimodal CBT, SFBT, humanistic existential, and systemic therapies. Yes, psychotherapy is the beauty of psychotherapy is using wherever it's needed, and she's a competent person. Current, she had had experience past both as a clinical psychologist in AIMS Bhopal and consultant. I like finally the corporate coach and trainer. That word I really love because it takes away quite a lot of negative baggage and brings up quite a positive baggage in terms of human dynamics. Without much ado, thank you, Sukanya. I'm really waiting for your wonderful deliverance of how to really do these therapies. And I'm sure the entire group is going to be happy to see your presentation. And I'm sure you are going to be detained for much longer than what you came prepared for, because there'll be a lot of questions. And my young friends, Aleem and Amrit, will go through those. Thank you very much for this opportunity. And I'm really, from bottom of my heart, thank each one of you for this. And I see already more than 150 people logged in. I'm sure it's going to be close to 200. Thank you. And Sukanya, all the best for you.
Thank you so much, sir, for that, for all those kind words about my work. And thank you so much for the warm welcome. I first would like to extend my gratitude for creating this platform to the brain behind this platform. And it is indeed a wonderful initiative that IPS has taken. And it shows the resilience behind this, the IPS, because making use of this time when we are talking about so much of the negative stress, the traumatic stress that is impacting everyone, not just the people who we heal, but us as well. It makes us realize, the human nature that all of us basically are at the core of our existence. So this is indeed a wonderful platform to not only deliver these important topics, but also to bring together all kinds of professionals in the field of mental health. And that in itself is a feat. Because to actually have so many professionals, not just from psychiatry, but also from the fields of, clinical psychology and social work as well, it is indeed a feat in itself. And that too at a time where communication is only through the internet, it just shows how much we have retained the spirit of community within the mental health professional community. So what I'm going to do is I'm going to just share my slides now. I will just switch off my video because that will help me save the bandwidth a little bit so that there's no interruption during the slideshow. And at the end of the slideshow, I'll put my screen back, the video back again. Thank you once again for inviting me for this topic. This topic, of course, is something very close to my heart. And as Sir rightly said, that I have been trained in the more traditional approaches of psychotherapy during my training at NIMHANS and even afterwards as well. But trauma therapy, as I got exposed to it about 2 years back, and in the last couple of years, I've been an active learner of this. And one thing that I would just like to point out at the outset is that the whole field of trauma therapy right now is like a vast ocean, and it's a very fast evolving field. It is quite new in India, but when we look at the amount of research, the amount of practice that is going on around the world, it makes us aware of how much of it has actually been built in the last 2 decades. And the depths of that is quite something to be able to actually grasp in a few years. I mean, to actually cover the field of trauma focused therapy in an hour or two would be an impossible feat. So I do have specific objectives today, and I would say that through those objectives, I would just offer maybe a droplet of that ocean of trauma therapy that I have been exposed to in the last couple of years. And like Sir rightly mentioned, that this is the time where perhaps trauma focused therapy is the most relevant. We have been hearing the words uncertainty and lack of predictability, unprecedented, so many times in the last 6 months. And probably this is the time where we have been reaching out to science to achieve more clarity, whether that be epidemiology or whether that be medical science, and now towards psychiatry and the whole field of counseling and psychotherapy. And therefore, trauma therapy in this time makes it much, much more relevant than it perhaps was perceived before this. And these are some of the subtopics that we will be musing over today. I will be going over and sort of defining in a more trauma-focused way of what exactly is trauma. We'll move beyond diagnosis to look at what is big T and small t. And then I'm going to introduce some key concepts in trauma therapy, like developmental trauma, transgenerational trauma. And we are going to understand the neurobiology of this trauma that is being talked about. And then I'm going to introduce the phased approach to trauma therapy and talk about the applications of it. A little trigger alert here that because this is about trauma, and we all have perhaps had that rendezvous with trauma at some point in our lives. The content may be triggering, so self-care is advised. Please take time by yourself.
And we will discuss about it in English. How to Train Your Dragon Part 1 movie.
Please do take adequate care to take time off and perhaps process things if something comes up. And that is key, because just because we are therapists does not mean that it may not trigger us. So we begin with a poll question here, and I would request the poll question 1 to be up, please.
Sure, ma'am. Just a minute.
Yes. So I have kept a few poll questions, not just to make it a little interactive, but also to gain a sense of where I am in terms of understanding my audience. So here's the...
Visible,
yes, absolutely, sir. It is visible.
Yes, it's visible.
So the question, you can click on, you can basically click on, as many choices as you want. It's a multiple choice. So why do clients with trauma histories drop out of talk therapies, so-called talk therapies? You may go ahead, click as many options as they resonate with you. You'll have to click on the options. Okay. I think the host will have to share the results.
Yeah, I'll share it. Just a minute.
Sure. Okay. So 65% of us feel that talking worsens their pain, followed by 52% feel that they don't want to talk about it. 39% feel that if they can talk about it with their family, then why would they pay a therapist for that? And 24% feel that sometimes clients don't want to detach from that pain, and hence they don't feel like talking about it. The whole premise of trauma therapy lies on that foundation that talking perhaps worsens their pain, which is why they don't want to talk about it, which is why they don't feel like dealing with it. And we will move on to define that this is what creates the impasse in therapy. And we have often encountered this impasse where clients refuse to talk about feelings about events, or clients keep repeating just the opposite. The clients keep repeating the same experience in session. They go over the same emotional loop, sort of. And how much of ever restructuring we do, how much of ever reframing we do, therapy just doesn't seem to move forward. And we encounter these lines, yes, I know, but I can't stop thinking about, I don't feel myself anymore. So this is where trauma therapy comes to our rescue. So a little thing that I wanted to also highlight is that when we say that this impasse that we reach is not just in terms of trauma survivors or so-called PTSD clients, but also in other presentations, which are increasingly being noticed in the diagnostic manuals. We have complex PTSD, and not just about the trauma-related disorders in DSM-5 and complex PTSD in ICD-11, but we also see similar kind of impasse in clients with dissociative disorders, somatoform disorders, personality disorders, eating disorders, addiction, and so on. So here's poll question 2. May I have the poll question 2, please?
Is it visible, ma'am?
Yes, sir. It's visible. Thank you. So we can go ahead, make the choice now. How can we heal trauma? You can click on the choice that you most agree with. I think we can look at the results.
Ma'am, it is still like people are voting. So
Okay, sure. We'll wait for a bit.
Pawan Patel, host, please mute all the other audios.
Yes, I have muted everybody, sir. Like people are allowed to unmute, so in between that happens, and I'm keeping a watch, so I'll mute them.
Okay. Please, actually, what is happening? Only unmute those people are to be because speaking like speaker and other 2, 3, 4, 5 people. Otherwise, it is sometimes disturbing. Okay.
Right, sir. Right, sir. I'll take care of it.
Thank you.
Great. So we have the results here. So I can see that we are kind of divided between by teaching the individual to make meaning of the pain and thus reprocess, or by desensitizing the triggers, and also closely followed by teaching the individual to be in the present, which is mindfulness, and not go back in the past, and by making the individual talk it out and thus reprocess. Well, honestly, what trauma therapy has taught me is that perhaps it's going to be a combination of all of these. And that's why the field of trauma therapy is so very deep as well as extensive. And there are so many approaches that have come up. And I thank everyone so much for participating in this poll and bringing out the perspective so that I know my audience a little bit. And as we move ahead, I have another question here. Can I have the poll question 3? So then what is trauma? You can click on the option that most resonates with you out of these 5. Shall we have a look at the results?
10 more seconds, ma'am.
Sure, sure. Okay, so we have 37% believing that it is the experience of a tragic event, 23% believing that it is an unprocessed emotion followed by a painful memory. Great. So we are quite close to understanding how in the field of trauma therapy, we have defined trauma. But before that, let's first understand what is not trauma. Because many a times we tend to sort of, be very inclusive in defining trauma. And we need to sort of delineate what, according to this trauma lens, is actually trauma. So trauma is not the event itself, because if we go by the event, then everyone who survives the event would have that kind of traumatic impact. But that's not the case, as we know. Trauma is not just the stress experienced in coping with the event. So we have another term for it, which is traumatic stress or post-traumatic stress. So that's not, the trauma is not indicated in the amount of stress experienced. Trauma is not in the narrative. So trauma is not in the construction of the event. It's not in the words. Trauma is not just the memory of the traumatic event. It is there in the disconnection. Trauma is in the experience where it feels that an experience feels life-threatening, even though it may not actually be life-threatening, but the feeling of it being life-threatening enough, that is what creates trauma. And we find trauma in the part of the self that survived by disconnecting from the rest of the self. Therefore, we find the footprint of trauma in this disconnected part of the self, which is the term dissociation that has been used in literature for all these decades. This disconnected part of the self is mostly not stored as words and is stored implicitly in feelings and in sensory experience in the body. The brain's response to trauma is not usual. This is a different kind of brain under trauma. And trauma, therefore, is not rationally stored. It is stored non-rationally as non-words, as we just learned, that in terms of feelings, in terms of somatic experiences or sensation. Trauma is also sort of the brain getting locked in time and not knowing that that experience is over. We often find a lot of episodic memory deficits in survivors of trauma. And therefore, trauma also prevents new learning from happening. Trauma is also personal and subjective, because what is traumatic to someone may not be traumatic to the other person. So, and overall, it impacts how we make sense of what we survived through, how we make sense of those different chapters that form our lives. And therefore, trauma largely lies in our sense of experience of the event. Therefore, it's subjective. So let's look at this definition of trauma, which is largely the most accepted definition of trauma. And I've just highlighted the relevant words in bold. Trauma is the unique individual experience of an event or a series of events or a set of enduring conditions in which the individual's ability to integrate his or her emotional experience is overwhelmed, or that is, his or her ability to be present, understand what is happening, or integrate the feelings and make sense of this experience gets impacted. So what we see here is that this sense of disconnection, this sense of being overwhelmed and disconnected can obviously happen under big traumatic events. And this is the first term in trauma literature that we encounter, which is the big T. Now, these big Ts are usually time-bound events. These are usually validated by others as, something really big enough to have survived. They're too stark, to be overlooked in our normal lives. And these could be examples of, collective trauma that we are going through right now. Or it could be something that an individual is going through by themselves, or like an accident or a sexual assault or a natural calamity. However, what's interesting is the concept of small t that trauma literature brings about. Small t's are like interpersonal troubles, financial worries, relocation, legal. Small t's are not time bound. So they may be an ongoing event, like we read in the definition, enduring conditions. Mostly they can be invalidated, both by the society and by the individual. because they seem just too trivial. They seem just too everyday to be considered as something significant or traumatic. And nevertheless, their size, that they're really something insignificant, when they continue over a period of time, they can have a cumulative effect which can be bigger than a big T. And often, because they are not validated, they are not recognized by the person as something significant, they can be forgotten or suppressed or, sort of not accessible by the individual. It therefore needs to be investigated by the clinician. For example, getting bullied in school, rebuked, repeated sexual transgressions, to even something really irritating that happens when we commute in long traffic every day. And if that happens over a long period of time, that can be defined as a significant amount of small t. The concept of small t in trauma literature is a great leveler of sorts. It sort of reminds us why some of us are wounded healers, because this is more common and probably is something that all of us go through. It also makes us understand that no big T or no small t is probably big enough than our entire selves, our whole selves, our holistic selves. And this brings us to the concept of how trauma itself leads to resilience, leads to the emergence of resilience. Our brains are social organs. Our brains are supposed to integrate information from the external world with things going on in our internal worlds and, be able to move on. So our brains have a certain kind of agility built into them. Trauma actually interferes with that agility. Trauma makes our brains immobile. And like we saw, it gets stuck in time. Yet it is the spirit of resilience, it is the quality of resilience which trauma can sometimes, sort of kickstart, which helps the individual realize that I am much more than what is happening to me now. And this leads to the concept of adaptation and resilience. However, what do we do when there is trauma all around, where there's trauma transmitted from one generation to another, where all you can see around you is trauma? That is the concept of transgenerational trauma. And that kind of trauma, which is something which becomes, a cumulative effect of probably some big T's and small t's as well, is something that defines our identities and dominates the story of our lives. So it recreates the social realities that we live in. Transgenerational trauma is something that cannot be ignored in the context of the modern world, because there are so many transgressions that have been happening in human history. And probably the more we have moved towards modern times, the more of these transgressions have happened. And the more of transgenerational trauma that we are seeing. And we see different ways in which we dissociate from that transgenerational trauma. What is important here is to see this relationship of trauma and how our identity shapes in the aftermath of trauma. How does the sense of self get impacted in the post-traumatic stress? The first work in this regard that I would like to highlight is the work of Alan Shore. And that is something which defines the whole concept and the importance of attachment in the development of not just early emotional bond and therefore emotional capacities, empathy, etc., but also the emergence of the self. And this in Shore's work, we see that it's very neurobiologically grounded, because the absence of an attachment relationship early on in life can lead to restrictions in development of the parietal cortex. And the parietal cortex is the seat of the sense of self, as we see. But more recent work talks about two different kinds of sense of self. One is the cognitive sense of self. That is our perception or our metacognition of what we feel inside, or how we think of ourselves, or what our thoughts represent, how our thoughts represent us. But there's also a sense of somatic sense of self. And this sort of delivers what we often cannot express in terms of our thoughts, but that sense of what our bodies tell us about, who we are, what are we experiencing. And these are the somatic symptoms that we often encounter from our clients, where we are not able to get into their thoughts or even their feelings. I'm sure a lot of CBT practitioners would agree that it gets so difficult for them to even create that thought diary, because it's so difficult to get what are you feeling and what is the thought behind it. But this somatic sense of self manifests itself in a lot of somatic symptoms like indigestion, or they say, I feel short of breath, or that I have a frequent headache. And this often represents the somatic sense of self. We often hear our clients saying, often trauma survivors saying something like, when I look into the mirror, I don't like what I see. So that sort of reflects their relationship with themselves. And that shows us how the sense of self gets impacted post-trauma. More recent work in the 2010s with the default mode network, which is basically a network of brain centers which connect important aspects like autobiographical memory and the entire theory of mind, which helps us understand what are others thinking and feeling, as well as this sense of self that emerges. So our sense of self emerges from all these different flavors that the default mode network helps us understand, and it sort of helps us understand what we are now and what we can be in the future and what we were in the past. So it sort of unites the history of ourselves in the past, now, and ahead. So the default mode network in traumatized individuals shows that they tend to spend more time in the posterior default mode network circuits, and the DMN circuits, which are more posterior, indicate that they spend more time in the past, because the posterior circuits, which includes the temporal circuits and a bit of the insula as well, so that that shows that they are sort of drawn towards their past. Whereas in healthy individuals, we tend to spend more time, our DMN scans show that we tend to spend more times in the parietal area, which is our somatic sense of self, or in the frontal part, which is our sense of who we want to be or what we want to do in the future. So there's a clear sense here that individuals with trauma in the post-traumatic zone, they tend to spend much more time in the past, and they're not really here, they're not in the present. And interestingly, this is the default mode network is usually the network which is there when we're not doing anything, when we are kind of in a suspended state. However, the default mode network, when scanned under threat, a subliminal kind of threat, very interestingly shows more connectivity. So it's almost like the default mode network in trauma survivors appear to be more latent, more suspended in the past, when not under threat, and suddenly when under threat, the whole brain becomes alive. So that's how it's different from the normal brain. And we are really looking at a brain response here, which is why these neurobiological explanations behind trauma therapy make it much, much more understandable, and sort of we can deconstruct it. And which is why it brings us to this important concept of adverse childhood experiences. And the ACE study was conducted by Anda and Felitti in 2003. They were basically running a clinic where a lot of women would come with obesity. So I don't want to call them obese women. So I'm going to call them as women with obesity problems would come. And what they saw was that many of these women were using their body weight as a kind of shield. And when they probed further with some questions about prior to your 18th birthday, were you sort of subjected to these experiences which map to abuse, household dysfunction, and neglect, they found that most of these women had a lot of these events in their life before 18 years of age. So this shows us that adverse childhood experiences are more common, and in the future they have been associated with 4 or more ACEs have been associated with lung disease, smoking, suicide attempts, developing depression, and a lot of these, even psychosomatic diseases as well. So the ACE study became almost like a landmark, and now has been translated into a tool that is often used to understand and scan through our clients' developmental histories to notice that if there could be a trauma component hidden there. So we have been talking about, trauma, big T, small t. So let me just kind of consolidate what are the different types of trauma. And I'm going to just take help of this beautiful tree diagram. It's called the trauma tree. The trauma tree essentially shows, just like for the tree, the roots and the bark are the most important parts. So similarly, the childhood, the early childhood, the childhood and the adolescence, these are the parts when really our resilience shapes up, where the personality is shaping up. So any kind of adverse experience during this time would weaken that base and not lead to that development of sense of self, a healthy sense of self. And this is what we would refer to as complex trauma or developmental trauma. And there could be components of ongoing trauma and transgenerational trauma, depending on the context of the individual. And it is quite possible that the same individual can go through collective trauma or acute single incident traumas or any sort of secondary trauma as well. The more the amount of these adverse experiences later on in life, it would just add to the trauma and perhaps not be able to, give them that chance to flex their resilience. On the other hand, if someone has not had these events, has had a relatively healthy sense of self, and then goes on to sort of experience maybe a collective trauma or a single incident trauma, would be able to overcome that much more easily than the others that we talked about, perhaps because their sense of self is intact, perhaps because their resilience has had that time to be cultivated during the growing up years. So we see the importance of resilience and how it sort of points out that no matter how big the trauma is or how many small t's we have, what matters is that how much of it is actually holding us back and what kind of impact it's been having on our adaptation and resilience. We're going to move on to the trauma response, and we know that all roads lead to the amygdala when we talk about trauma. And we know that there are two ways to the amygdala, and we know that the thalamus has a short route and a longer route. And we also know that basically trauma lies in the short route. That's where the hijack really happens, and that's stored that way. So every time the sensory thalamus is again met with the same kind of trigger, we get the same hijack response. So the longer route is literally cut off, and that's what is explained by the hand model of the brain, or the model where we talk about how the top of the brain flips because this circuit is activated, so the longer route is not going to be accessible by the individual. Let us go a little deeper in this. We want to understand, why does this connection happen? We may be aware of MacLean's model of the triune brain, which basically talks about how the brain has phylogenetically evolved. And basically the human brain has literally got three layers, one sitting on top of the other. And at the base of it is the lizard brain, which is the survival brain. Then we have the mammalian brain, which helps us connect with our environment and develop that attachment. And then we have the most special part of the brain, the human brain, that helps us do all sorts of sophisticated stuff that we do. So what happens in trauma is that, we call it the hand model because we say that the top of the brain flips. But why does that happen? That happens because the lizard brain gets overloaded with a lot of information about safety and security. And when the lizard brain, the brain is phylogenetically has evolved in such a manner that if the lizard brain is activated, then the limbic system and the lizard brain are going to get cut off from the neocortex. In fact, the point where the neocortex connects with the mammalian brain, with the limbic system, which is the orbitofrontal cortex, literally shuts down at that point of time. So what we have is the lizard brain and the mammalian brain, the lower parts of the brain, or the downstairs brain, as Dan Siegel calls it. The downstairs brain sort of gets active, and the upstairs brain gets dissociated or disconnected. So the downstairs brain and the upstairs brain are no longer working together. And these downstairs parts of the brain are actually working towards ensuring that the individual is safe and secure. So first, ensuring if there's safety in the environment. Only if there's safety in the environment will this overload decrease, and then this channel is going to open up and the neocortex is going to be back to normal. So in order for the human brain, the neocortex to function, we need actually the lower parts, the downstairs brain, to feel safe and secure. And that's a huge learning, because we now know that when trauma strikes the brain, it is stored in an implicit manner, and we do not recall, the cognitions at that point of time. Any kind of cognitive experience that is remembered would be the reconstructions later on about what we think we went through. And the trauma trace is really in the form of an image or a feelings or sensations. And that is what Bessel van der Kolk calls as the body keeps the score, how the body, the somatic self constantly keeps track of what kind of sensations, or what was the internal environment like when a particular traumatic event happened. Now, I just want you to look at these pictures and try to sort of find the commonality. What we see here is that in all these pictures, the dyads, the couples, whether that's a mother and her child, in the human or the primate or the set of birds or this couple, their faces are towards each other. They're facing each other, and I want you to sort of focus on the upper part of their faces. Where are they looking at? They're looking at, there's some kind of eye contact happening. There's some kind of opening up of the upper part of the face. And I want you to look at this picture. Here, across these pictures, we see there's a certain sense of surrender. There's a certain sense of people are no longer, these animals also are no longer looking at each other, but their bodies are closer. And there's a sense of surrendering of the bodies as well that we see. What I'm trying to show you is this amazing concept of the polyvagal theory, which has been given by Porges, Stephen Porges, in 1995. He talks about that these sensations of safety and security can only be created in the nervous system when the third part of the vagal nerve, which is basically the ventral vagal nerve, the myelinated ventral vagal nerve, when that gets activated, it's only then that mammals are able to feel safe. They're able to sort of engage in being free, being able to love, being able to feel compassionate, being able to feel curious. So all these characteristic features that makes our mammalian brain, give us that human touch of compassion, curiosity, and that sense of being productive, that can only happen in that zone of neuroception of safety, when we are feeling safe, when the ventral vagal is activated. And the ventral vagal may not be activated if either the sympathetic nervous system or the dorsal vagal gets prominent. In his polyvagal theory, Porges talks about 3 parts of the vagal system. The ventral vagal nerve, what it does is it kind of decreases the connection, the sympathetic activation to the heart, and it increases the connection between the face and the heart. So that's when, which is why in the preceding pictures we saw that the safer we feel, there is more contact, there's more closeness of the faces, the upper part of our bodies. So that's the face-heart connection that the polyvagal theory talks about. And notice how important these concepts are in our sessions. We often find our clients looking away, not making eye contact. And that is probably the first sign that they're not feeling safe, that something's coming up in their implicit memory. How can we handle it at that point of time when we know that they're not feeling safe? There are multiple ways. We could begin with requesting them to make eye contact, or we could begin with figuring out how we can feel them safe in that environment. And when we move up this graph, we see that the sympathetic nervous system gets activated in that neuroception of danger, which can either be a fight or flight response. But when the threat is just too much and the sympathetic system can get into an overdrive, that's when the dorsal vagal sort of takes it up, and that's the brake system in the brain. This is where the brain is communicating to the individual that I can't deal with this. And if I have to deal with this, I'm probably going to die. So it's better that I sort of feign dead, or I just freeze, so basically what's happening here is that the reptile brain is just active and everything else is just shut off, and only the vital functions are on. So this is how Porges describes the different stages of neuroception of threat, and how it's important to understand where our clients are, which zone of the polyvagal activation are our clients at. And when we realize that they are in either of the sympathetic nervous system zone or the dorsal vagal zone, we need to first ensure that they come back within that zone of safety, or the ventral vagal is activated. Only then we can, sort of engage in a conversation or even talk about what they are experiencing. So this is a very important insight when it comes to the trauma literature. And this idea of neuroception, it is truly defined as the sixth sense, because it's different from perception. It's almost like this neural system has evolved, this system which does not rely on our perception, does not rely on our senses. It is a neural process that has evolved to learn to distinguish between what is safe, what is dangerous, and what is life-threatening. There are three kinds of neuroception. One is exteroception, that is the neural system's ability to detect threat in the environment. And there is interoception, which is sensing the internal environment, any changes in bodily tone or any changes in our internal environment. And there's proprioception, which is the sense of the position or movement of the body. So these three in all give us an idea of where we are. Is there anything to worry about in the environment, and how are we feeling inside our body? What we notice in people who have, in the aftermath of trauma, what we notice in traumatized individuals is their sense of interoception is really something that is damaged. So with a lot of clients, initially, when we ask them the question that, can you tell me what you feel inside your body? Many of them are blank to it. So that is again one sign that they have survived significant trauma in their lives. And the more of this neuroception there is in the nervous system, according to Dan Siegel's interpersonal neurobiology theory, our brains tend to be in the reactive state, which is more of the dissociative state. There's more stress, so there's more of the reactive action happening, and there's more dissociative experiences happening. Whereas the more ventral vagal dominance that is there, the brain tends to be more receptive. And as a result of receptive state, there is more integration happening between the external world and the internal world. And that's exactly what the brain is supposed to do. It's supposed to integrate. And that's the agility that we were talking about. And if the brain is able to integrate, then we don't need trauma therapy. But that's where we are. Our brains are human, and our brains tend to engage in all these neuroceptive abilities, detect threat, and there are threats, as we saw, the concept of transgenerational trauma as well. So the more dissociation, the more reactive states, the more feeling of getting stuck in time, the less we are in the present. So that's where the two poles are. Trauma therapy sets to bring clients more towards the receptive state and be able to integrate the external world with the internal world. And this brings us to the whole idea of the sense of self. To bring back once again, we know that the sense of self is not really unitary, although we talk about self-concept, self-image, but we know that there are multiple such self-images that we have in mind. So the self, in a sense, is not unitary. And this is what we see in trauma, that the compartmentalized parts that could be images or emotions or sensations or the meanings that we have made out of those experiences, those parts are held in certain neural circuits, and those become the compartmentalized parts or the fragmented cells. And this part once allowed survival, but now is avoided because they bring up those unpleasant emotions. We can choose to call them parts or wounded child or ego states or states of mind, internal objects or part cells. Many such nomenclatures exist. But what essentially they show us is that the self gets fragmented and we see the individual in fragments. The more there are such fragments, the more dissociation that's there, the more indication of a greater amount of trauma, probably complex trauma. And the more our clients move towards being able to integrate these selves through the process of trauma therapy, the more there will be this emergence of a single feeling self, where the individual is aware of the different parts, but is no longer in a state where they have to avoid any of the parts. All the selves, all the parts of the self coexist with compassion, with love and curiosity, and is aware of each other. So trauma interrupts this sense of self. Trauma interrupts the autobiographical memory, as we saw. What happens when our clients get re-traumatized, when they're asked to recall any event of trauma? What happens then? So as we saw, that the shorter route gets activated and the amygdala gets hijacked and the past becomes the present, because the amygdala is almost like stuck in time. So the brain tends to feel that, okay, it's happening again, it's happening again. So the response is going to be the same again. And this theory of window of tolerance, this model really helps us understand this re-traumatization concept, that when something triggers off and our clients are going back to that original trauma trace, there can be two kinds of reactions that we see in our clients. And this really helps us organize the material that we can use in our trauma tools. And it also helps us understand where we want to navigate to, how do we bring our clients back into their stable selves. This is also a wonderful piece to actually psychoeducate our clients about. It's a wonderful piece to actually introduce them to the language of trauma therapy, of how our brains behave in trauma therapy. In fact, in trauma therapy, we do use a lot of psychoeducation. It's important for clients to understand that this is how the brain behaves in trauma. It is not them. So when we look at this window of tolerance model, as you see that Siegel defines this window as a natural width of our tolerance levels, how much of a particular emotion we can tolerate, how much of anger is tolerable for us, how much of sadness is tolerable for us. And beyond that, and sometimes this window can decrease. This window is really dynamic depending on the circumstances within and outside. This window can really decrease. You know, sometimes when we are too much, there's been too much of trauma, the window can become really narrow. So which generally translates to the individual flying off the handle or going outside the window of tolerance every now and then, pretty often. And we can then enhance in the process of therapy, we can then help them broaden that window of tolerance. Now, what happens when clients go outside this window of tolerance? They can either move outside up, which is the stuck on phase. There they experience the symptoms that are referred to as hyperarousal. This is the state where the nervous system is in a hyperaroused state. So all the symptoms that we see are of the sympathetic activation type. So there's anxiety, there's panic, there's hyperactivity, there's restlessness, there's hypervigilance, there's sleeplessness. So the nervous system is in a state of hyperarousal. Vis-a-vis the other side, where the nervous system can be stuck off. So this is the zone of hypoarousal, where the nervous system is below the optimal arousal state. And here we see, experiences like disconnection, or feeling low, or feeling depressed, or fatigued, or even dissociation, different states of dissociation. So these are also referred to by our clients as zoning out, or I just checked out, those kind of experiences. So when we see that there are these two clear-cut different kinds of hypo and hyperarousal symptoms that we see when there are any traumatic triggers and our clients are moving outside their window of tolerance, we need to first understand which is happening more of, or which is happening when. Needless to say that both cannot happen at the same time, at the same moment of time. Of course, the individual can fluctuate, which is what we see usually in PTSD clients, that they fluctuate between these two states. But the kind of tools that we will use to bring down the arousal from a hyperaroused state, and the kind of tools we will use to bring up the arousal from a hypoaroused state are going to be very different. So for example, if our client is in a panic state or extremely hypervigilant, we usually do some kind of relaxation. We ask them to breathe out. We ask them to sort of like blow out a candle, or we ask them to do JPMR, or we ask them to sort of do any kind of breathing, use their breathing in a way that can relax them. So that's basically to get the parasympathetic nervous system kicked on. But if we do the same thing with the hypoarousal symptom, we risk sending the client off into further hypoarousal. So that's where we need to know what kind of techniques would be useful for the hypoarousal symptoms. For the hypoarousal symptoms, more of what are known as grounding symptoms are required. So we need to sort of help the individual gain an anchor, a connection with the environment. Because I just want to connect this with the polyvagal theory that we just talked about. So this is the zone where the dorsal vagal has been activated. So the social engagement system, which is activated by the ventral vagal, is cut off. Because the social vagal is cut off, what we see usually is that their faces are turned towards another direction. They're not making that eye-to-eye contact. Their upper bodies seem much more stressed out, and the face-heart connection is not activated. So therefore, we need to engage them in activities which can bring back that face-heart connection, which can make them feel grounded in where they are now. So the grounding activities which can get them back in touch with their senses, get them back in touch with the environment, get them back in touch with whoever they are with, get their social engagement system, the ventral vagal activated. Those are the tools that would be used for these group of symptoms. So as we saw that this concept is a very useful concept to help us navigate how do we help our clients come back to their window of tolerance and what kind of tools might be useful. So now we move on to trauma therapy. I just want to introduce a brief sketch of trauma therapy. And as you will see that it's not very new. And in the early 19th century, we had Freud and Charcot and Breuer talking about the concept of trauma, but in the language of hypnosis and dissociation. But it was the wars, actually, the world wars, which turned our attention towards the shell shock syndrome and sort of, took away that emphasis on dissociative states and introduced the whole idea of PTSD gradually. So we didn't have a name, of course, till about 1980s when PTSD was introduced in DSM-3. And then on, we began focusing more on the PTSD-like symptoms, which is, of course, a big T. And they look at the hyperarousal and the hypervigilance, and also the dumbfounded expressions as well, where basically the client has gone into the hyperarousal zone. So there was more focus on that, but it was really in the late 1990s with the emergence of polyvagal theory and Dan Siegel's window of tolerance as well. These concepts really brought forward a lot of change in understanding what trauma is and what is the impact of trauma on our nervous systems. And this led to the whole lobby of Bessel van der Kolk and other psychiatrists as well, lobbying for the whole concept of developmental trauma disorder for DSM-5. That did not come through, of course, because there's still lack of evidence to establish that as a category. But in the 2008-9s, we saw the emergence of sensory motor psychotherapy and somatic therapy, somatic experiencing, Peter Levine somatic experiencing, that started gaining prominence. And we also have the integration of these body-based psychotherapies now with a lot of other oriental disciplines like yoga and Tai Chi in the recent years. And now we do see complex trauma having been introduced in ICD-11 as a diagnostic category. However, DSM-5, as we know now, that it has taken out PTSD from the group of anxiety disorders to at least acknowledge the essence of how trauma can be leading to these manifestations. So these are the different types of trauma-focused therapy. You have PATHS work, which is internal family systems, or IFS. It can also be inner child work or inner critic work. So these are essentially therapies which help put those fragmented parts of the self back together. And once we have been able to establish that, we are able to, get the sense of self back. And that is how we can heal our clients. We also have somatic experiencing, which has been proposed by Peter Levine. We have sensory motor psychotherapy, which is Fisher and Ogden's contribution to the field of psychotherapy. We have EMDR, which is eye movement desensitization and reprocessing. And we have neurofeedback. Now, EMDR has been the frontline therapy for PTSD for quite some time now. Neurofeedback is showing a lot of promise now in terms of treating developmental trauma, where we know that the sense of self was never established. So like we talked about in the types of trauma, that if the sense of self was established, but due to trauma got fragmented, we have ways to put it together with PATHS work or any of the others, with body psychotherapy as well. But when the sense of self was never established because of early developmental trauma, and with the entire transgenerational trauma, and Alan Shore's work talks about that. That's when neurofeedback holds a lot of promise. It literally trains the brain to regulate itself. And that's where the self is recreated at an adult age. We also have trauma-focused CBT, compassion-focused therapy, and narrative exposure therapy. So like I said, that this is a huge ocean of psychotherapy that has come up in the last 2 decades. And what I'm offering you right now is literally one drop. Most of these psychotherapies, most of these trauma-focused therapies, including EMDR, neurofeedback, TFCBT, sensory motor psychotherapy, somatic experiencing, IFS, require intensive training and certification, without which we cannot practice it, because they do have a protocol. So the protocol has to be followed. And these are intensive protocols and trainings that need to be taken over a period of months or even years. And they help us get a sense of what the client is presenting with, what should be the treatment plan, and what can be the tools that can be used, and what's the process. But broadly, this is what Herman's work in the 1997s that really brought about this idea of phased approach to trauma therapy. So there are 3 phases, as Herman says, that there's the first stage is stabilization, where we literally have to regulate the client's brain. This is where the client presents to us with a lot of these hyperarousal or the hyperarousal symptoms, and we literally have to work with them to co-regulate their brains, and then to teach them these stabilization skills so that they can come back to their window of, come back inside their window of tolerance. So that first phase is stabilization, which is extremely crucial. Without this, we cannot really move forward in trauma therapy. And this sense of stabilization can be quite complex, because many a times we can assume that our clients have become stable, but there are indicators of stability. And if we falter on the lines of re-traumatizing the client, that's totally against the whole ethos of trauma therapy. So there's a fine line between training the client to sort of reprocess, and training them to be stable enough to reprocess, and recognizing that therapy might be actually re-traumatizing them. So all the approaches that I talked about of trauma therapy bring in this important concept of re-traumatization, and how therapy itself can be re-traumatizing for clients. So we need to be very, very careful of our clients' well-being before we venture into that. The next stage after stabilization is reprocessing. So when the client has developed that stabilization in their sense of, their sense of regulation, they're able to regulate their brains, they're able to come back within their window of tolerance, then we can actually proceed to reconstruct the traumatic event or the traumatic memory. So depending on the kind of therapy that we are following, EMDR has its own protocol, IFS has its own protocol. So each of these therapies have their own protocol in which the traumatic event or the trauma itself is reprocessed. And we need to ensure that throughout these 3 processes, throughout these 3 phases, the client remains stable. So which is why Herman also says that the 3 phases of trauma therapy are stabilization, stabilization, and stabilization. We only need to teach the brain to stabilize. The brain has its own adaptive capacities, and with stabilization, perhaps the brain develops its own capacity to reprocess and become that one single self again. So that's the last phase of trauma therapy, where we sort of integrate the client with their daily lives, or integrate the event with their autobiographical memory as well, with their narrative as well. So these are the 3 phases of trauma therapy. I'm just going to briefly talk about the trauma lens and the difference between trauma focused and trauma informed lens, and then the ethical aspects of it. So the trauma lens has these 4 important components. One is that it definitely looks at the context of the client, the prevalence of small t's, and dissociative experiences. These are the 3 things which help us understand the conceptualization, develop the trauma conceptualization of our client. The second aspect is respecting the client's discomfort, respecting the client's history, and avoiding re-traumatization. And this is where much of the unlearning happens. Because for a trauma therapist, it's not important to know what happened to the client. It's more important to know what's happening now to the client. So in that sense, respecting the client's privacy, respecting the client's confidentiality, and their, respecting to not re-traumatize them by asking them questions about the event or showing too much of curiosity in that is crucial here. And the third chunk is about building adaptation, stabilization, and resilience. which I talked about, that that's the pillar which is the most important pillar in trauma therapy, without which none of the others can actually take place. And of course, then we are actively reprocessing the trauma here. We are taking the traumatic memory trace, or we are actually taking the most wounded part of the personality and processing that. We are reintegrating the fragmented selves. We are helping the clients build a new narrative. And this is where it's different from trauma-informed care. Trauma-informed approach does not require us to deal with the trauma itself. If we are just cognizant of these 4 R's, which is to realize that trauma exists in probably all in the social fabric of our communities, and it's more common than we might think. We need to be able to recognize the signs and symptoms of trauma. We need to be able to respond to those needs in our clients with changes in terms of our practices, or probably develop policies as well which take care of those responses, and then actively prevent any kind of re-traumatization, especially of children and adolescents. So these 4 R's of trauma-informed care is something that defines something that highlights the difference between trauma-informed care and trauma-focused care. So in trauma-informed care, we are aware that we are dealing with it, but we are not going to heal the trauma. But in trauma-focused approach, we actually engage in protocols to help the client heal the trauma. These are the different applications in which the evidence base has started building up. There's PTSD, there's dissociative disorder, somatoform, eating disorders, addiction, personality disorders. There's domestic violence, and even violence between couples as well. There are different forms of therapy that help us do trauma therapy with couples as well. There's emotional disorders in children and adolescents. There's secondary traumatic stress, which is STS, and attachment ruptures. So these are the emerging diagnoses and distresses where we are able to apply the concepts of trauma therapy, and the evidence base is slowly building up. These are some of the trauma assessment tools which are useful and absolutely necessary for understanding dissociation, of how much it happens, because dissociation is not something that is common in our language, or something that is acknowledged or even understood by clients. So it's important to be able to assess how much of dissociative experiences are actually happening with the client. There are different such scales for adolescents and for children as well. There are different attachment interview schedules which help us understand what the attachment of the client was like. There's of course the ACE, which I talked about, but more than any of it, what is the most important tool, the gold standard, is trauma-informed history taking. This kind of history taking takes the utmost care to not re-traumatize our client, not talk too much about the events that had traumatized them. And briefly, I know that I'm kind of overshooting the time, but these are basically the highlights of the ethics that we need to follow when we are doing trauma therapy. The foundation of trauma therapy is about respecting the client's subjective experience. So the clinician does not need details about the experience, or does not need to verify the events in the client's life. This enables us to not re-traumatize the client, and helps build the trust between the client and the therapist as well. The second pillar is about how we need to respect the consent of the client. So trauma therapy always informs the client about what the therapeutic approach is, what are the risks, and what will be the boundaries there. What is the evidence base? In fact, in many of the trauma therapies, we do also talk to clients about what is the evidence base of that particular approach. A lot of somatic experiences are also used in trauma therapy, like you saw. So there is sensitive use of touch, and there's also the sense of how much can be actually disclosed to clients, and using that sense of responsibility for the therapist to disclose as much as is required. The third most important pillar is about assessing risks, because we know that a lot of our clients do have suicidal tendencies, whether that is non-suicidal or actually associated with suicidal ideation, active suicidal ideation. So assessment of that and the therapist's competence in handling such criticality is important. So with that, I'm going to end and open the session up for comments, questions, and as this quote says, that this perhaps is the time where trauma science is not just timely, but also time sensitive. So I hope that with this, I've been able to give all our audience today a brief view into trauma therapy. And like I said, this is just a small droplet. And I hope that I've been able to ignite your interest in the field so that you can decide which one of these therapies are of interest, and you can pursue their specialization and the certifications, and be able to then feel more, feel more of your therapist self in terms of helping your clients with trauma histories. So I'm going to stop sharing the screen and switch my video on, and we can then open it up for questions. Thank you so
Sukanya,
much.
Sukanya,
Yes, sir.
Sukanya, you have entered pretty magic to us and showed to us, I think, really wonderful. My opening comments are only, I think you have given quite well about the therapy part. You explained the neurobiological basis so that everyone who has listened to you right now know very clearly what happens. It's not just, but the third part of it, which I would really love, is that now you have thrown yourself for more lectures to us. And I'm sure Amrut and will definitely come back to you. What I was thinking is, whatever you told is conceptualized very well with us. Now, to a large extent, I'm more knowledgeable today, and I thank you very much for that. But I think we are looking for, I look for one doubt. I need one or two examples of what is transgenerational trauma. Some examples in real cases. And what I was suggesting to the organizers is that you might come back to us with the real cases in a, how do you actually do the therapy? There are other psychotherapies. How does this psychotherapy? Some of the rules which you told apply to most psychotherapies also. The boundaries, staying and all that. The rules are there for each therapy. So how does your therapy? But I would thank, and now I think I'll give back to Amrut, because this, I was too tempted that I cannot stop with the, after listening to such a beautiful lecture.
Sure.
Thank you.
Please mute others who are not part of the. Please unmute Dr. Dalal sir. Sure.
Dalal sir, your comments please. Dalal sir.
I would say an excellent presentation. It opens up, I mean, a lot of things. Trauma, you have summarized it well regarding trauma, and when to say how to reconstruct it, or be very careful, because when we were students, there have been a quite amount of dilemma or controversy as far as debriefing is concerned, that whether to debrief or not to debrief at the initial moments. Because after doing my MD, I worked for 4 months in Bhopal gas tragedy disaster. And there I was posted as a senior research officer of ICMR before I got into my lecturership in my alma mater at KGMU. So there were a lot of things where people were associated with, and say at that time the talk of compensation was going on a lot. So people were associating even, I mean, the cataract is happening because of gas the gas, and any other happening because this is because of gas, and so many other things. So, I mean, as far as the disaster and trauma therapies are concerned, there is, we all know about compensation neurosis, and we talk all the time about compensation neurosis. That is the other part of it, of course. So we will have to be very, very clear and very, very cautious about it, that what to do and what not to do, what should be tell to our clients and what not, and when to reconstruct it. Because as you have said that unless we stabilize the person, I mean reconstruction of the traumatic event will really be rather it will be harmful for the person than helping him out. So with that, I think that it's a new area and it will bring a lot of questions and lot of clarifications. Thank you.
Thank you, sir. So thank you, Sukanya, madam, for a beautiful presentation. It was very, very impressive. So what made us think about this topic was basically the fear related to COVID and all. So a very pertinent question from a very, very senior psychiatrist is our mentor, Dr. Vidyadhar Vatve, sir. Can COVID-related fear be considered as a trauma? And how to deal with these things in terms of whatever theories you have thrown on us today?
Yes, absolutely. This is a very, very pertinent question in the current times, and there's a lot of literature that is emerging about how do we look at COVID as a traumatic stress. There is no doubt anymore that COVID is a traumatic stress, a big T. It is known as a collective trauma. So the kind of terminology that we use for such a pandemic is collective trauma, meaning that all of us are going through the same thing. However, the uniqueness about this COVID stress is that even though we are going through the same thing, it does not have the same impact on each of us, because it seems to be interacting with our individual levels of already existing trauma, the small t's that we have in life, and the resilience that we have developed in ourselves, which is why a lot of research has also started in terms of understanding how this trauma is unfolding, because there is this sense of this trauma not ending, and that is harming our nervous systems beyond any shred of doubt, because our nervous systems are constantly pushed into that threat mode. So our basically we are constantly seeking out for safety, security. Even within our homes, we are not feeling safe anymore. So what we are in fact seeing in trauma focused approaches right now when we are practicing it is that a lot of existing clients with trauma have worsened in this context. And a lot of clients who had been deliberating upon starting therapy have actually contacted now, because like I said, that it's kind of precipitated more of the trauma reaction and made the client sort of realize that this is probably the time that they need to get to it. What is being suggested by trauma therapists across the world is that because the limitation right now posed by COVID itself is that we cannot have in-person therapies. And in trauma therapy literature, the whole dyadic regulation between the therapist and the client is of crucial significance. The human aspect, the presence of the therapist, how the therapist is responding to every micro moment in the therapeutic space is extremely crucial. And because that in-person element is not something that can be completely created in teletherapy, what people are suggesting is that what trauma therapists are suggesting is that we need to use teletherapy sessions to ground our clients, to help them stabilize. So the metaphor that is being suggested is all hands on the deck. So which means that we need to encourage our clients to use all possible resources to ground themselves to survive these times. And after this major stress is over, maybe after the vaccine comes out, or maybe after we have learned to live with this, we need to then look at how we can help our clients reprocess the trauma that emerged out of this. So it's really something that is unfolding, and we need to keep track of what kind of traumatic stress we are seeing in our clients, but keeping the focus more in terms of stabilizing the client as of now.
Thank you. Thank you.
Sukanya, I think, Sukanya, when we talked earlier, we threw a challenge that people should ask another session for you. So I think there are too many comments. People are asking another session. So we can discuss about it later. Darpan has asked, Dr. Darpan, which formal school of psychotherapy, trauma-based therapy belongs to, and what are the levels of evidence? And another question, that how are trauma-based interventions qualitatively different child as compared to adults. So any developmental considerations there?
Yes, of course. Yes, of course. There are a lot of considerations when it comes to treating the child with trauma, the adolescent with trauma. In fact, for being a child and adolescent trauma therapist, we need to sort of be able to translate all of this literature into a child-friendly language or an adolescent-friendly language. There are a lot of metaphors, and even the stabilization techniques that are used for an adult are kind of modified for the child. So in a sense, if I can give you a sense of, you know, how we kind of work with the client. So when we work with the hyperarousal or the hyperarousal symptoms, it's important for us to be able to use metaphors to explain to the child what is this window of tolerance like. Why do they need to employ those techniques and come back with that window of tolerance? So we use metaphors. One, we use a lot of jargon. So for example, we want to induce some kind of affect shift. So if the child is in hyperarousal mode, so we might want to teach them something like, okay, let's just stretch your hands and get into this mountain pose. So the child will stretch up their hands and get into the mountain pose. And then we say, now drop down like a spaghetti. And then they drop down. So the idea is that, you know, we bring their arousal down to an optimal zone, and the spaghetti pose is actually the target. But to actually get children to surrender so much and get into that spaghetti kind of zone, we need to first get them to the mountain zone. So there are modifications that are definitely used to navigate, you know, the whole field of trauma therapy with children and adolescents. It requires a lot of specialized training. So I think a lot of the questions that I can see on the chat also are related to that, you know, what school of therapy or what are the different techniques that can be used with children and adolescents. It does require training, so which is why it's outside the purview of today's talk. But I'm so happy to see so many questions coming up, and I think I have I have been able to pick all of your interest in terms of learning more about this field.
Yeah, that you have done. Just an add-on question: hyperarousal and hypoarousal. How to handle? How to use this in therapy?
Yeah, so there are different techniques for hyperarousal and hypoarousal. So like I said, that for hyperarousal, we would go for more of relaxation techniques. So it's very important to understand that are we assessing hyper and hyperarousal correctly or not? So if it is hyperarousal, the idea is to bring down the regulation. So you would use things that you're probably already using: relaxation, JPMR, breathing, and all of that. Hypoarousal is something where we need to bring up the arousal. So anything that can help our client connect with the environment. Simple things like orienting them. Ab aaj ka date kya hai? What is today's date? Aap kahan par baithe hain? Just look around and identify 3 things. You know, these sort of orienting activities can gradually bring them back to their senses. For hypoarousal, even dialectical behavior therapy also talks about some of the distress tolerance skills, where they are requested to use intense, sensations. For example, really invigorating smell, like the smell of coffee or the smell of a lemon or something like that, to bring them back to their sensory experiences. So those are different techniques. Again, there are plenty of techniques. Maybe if we, sort of are able to talk about this another time, then I might be able to tell you more about those specific techniques. But sorry about the fact that we couldn't.
Sukanya, you cannot just escape like that for the next time. We have got 2 or 3 clinical scenarios. One of my young friends from AIIMS has asked a very pertinent question. He had a female who was premorbidly very, very well adjusted. She lost her son a few days back. And, whenever she comes to him, whenever she talks, she actually dissociates. She wants to be with her dead son. And how to approach such a patient, how to deal with such a trauma, because we come across such type of trauma, death of a loved one, it takes away everything you have in your life. So how to tackle such a case? And then I'll be talking about another case after this.
Sure. I would say that, this is not something which I can provide any kind of specific leads right now, because, we need to have a more detailed analysis of what the client is presenting with and what are the grief symptoms like. Of course, grief therapy would be something, definitely the grief part of it, the grief work would be required. But at the same time, what they can do right now is to do a lot of stabilization. So to be able to see, right now the client is trying to make sense of what just happened because it's the loss of a young child. So we need to understand that we need to look at the momentary arousal symptoms that are there. Is it hyperarousal or hypoarousal? And be able to regulate that, be able to help the client just micromanaging those moments of hyper or hypoarousal. There must be, like you said, that there are more dissociating states happening. So those dissociative states need to be brought down. So in order to bring down dissociative states, as we discussed, we need to increase the arousal level. So more of grounding activities. So like I've been saying, you know, orienting them. Where are you right now? Allowing them to cathact for a while, but then allowing them to come back and orient themselves to where they are. What is the date today? So even these simple questions orient the nervous system to the here and now, to the present. And that is what is missing in our trauma clients, that they lose that touch with the now, with the here and now, with the present. They're no longer in the present. They've gone back to that moment of losing their sight. So we need to constantly bring them back to the present. I would say that right now we should only focus on that stabilization, only that aspect of bringing them back to the present, and not get into meaning making of the loss at all now, because the client is highly distressed.
So can I get the answer on transgenerational trauma? What is this? Because this seems to have one, rest of the things I did understand, but transgenerational trauma, you mean each generation has a kind of a different pressure?
Yes.
Can you put it a little more insight into it? It's
sure,
otherwise,
absolutely.
it helps.
Sure, sir. I wish I had more time to sort of show you a video perhaps of transgenerational trauma. It sort of helps us understand that throughout our history, our human history, there have been a lot of transgressions, whether that be with people who have survived wars, or whether it's about people who have undergone racism. And like we are seeing now, a lot of narratives are coming up about being discriminated because of our religion, because of our race, because of the geographical location. So these kind of forces that have come up of oppression, so these oppressive forces lead to marginalization. So essentially transgenerational trauma takes into account the experiences of marginalized communities and how this marginalization may be there in most of our in most of our experiences. At some point of time, either us or our ancestors, our previous generations may have gone through that. And even though we may not be going through that, but we have been exposed to those narratives. So for example, I can give my example here, disclose a little bit here. My parents are from Bangladesh. So I have been constantly hearing those narratives about when the partition happened, how their parents had sort of come in. So even though I am not sort of going through that traumatic stress now, but I have been exposed to that narrative. I've been hearing narratives about how partition has impacted people. So similarly, a lot of our clients, we hear about where they are coming from. So for example, if you're seeing a client from the western part of India or the northern part of India, I'm sure that you are exposed to different narratives about how the CAA would have impacted them. And those are essentially transgenerational components that we need to be aware of, because that defines the context of the client for us. Because the whole idea of trauma is very systemic in its outlook as well. We cannot decontextualize the client. It's not that, just like the COVID happening to us now, it's not just that the COVID is happening to it's not just COVID happening to us. It's a lot of other things. So for a client who has apart from COVID, our client may be dealing with job loss, our client may be dealing with things that they have been dealing with before. For example, there can be marital discord in the back of the picture. So those are transgenerational components which we need to be cognizant about and bring into the conceptualization of trauma.
Yeah, thank you so much. Adding to another question, this is another clinical scenario where one of the attendees have asked about a 14-year-old female who had CSA 6 months back. Currently, patient is dissociating, patient is irritable, patient is not studying, patient is having all sorts of issues. So how do we go about it? I know you cannot be very, very elaborative, but maybe just give us just direction on how we can deal with such trauma.
Yeah, sir, one thing that we need to understand in order to learn trauma therapy is the importance of self-care and supervision. So in trauma therapists, it's very important to know that supervision is an ongoing concept that is applicable when we are learning trauma therapy, especially because there can be so many of these complex presentations that we see in our client, and even though we may be well versed with trauma therapy, we may have been doing trauma therapy for years, even then supervision is important. So which is why I would sort of not I don't think I would even qualify to kind of supervise my colleague here for this. I would suggest them to seek supervision for the client that they're seeing, because this is an ongoing phenomenon that's going to happen. So a more sustainable option would be for them to seek supervision and develop a conceptualization of the client and be able to understand, prioritize what needs to be done first. So, because it's a 14-year-old and the trauma has just happened, what do we need to first focus on? Is there any risk? Is there any self-harm? Is there any self-harm happening? So those are the issues that I would be extremely concerned about given the age, and I would definitely be want to be more cognizant about the background of the client, in terms of, for example, what are the family dynamics like, what is the level of risk like, are there any past attempts, anything at all. So I would be very cognizant, and without knowing that, I don't think the trauma conceptualization can be done.
Thank you,
But in
Sukanya.
terms of, because, whenever we see dissociation happening, I just want to remind that dissociation means a kind of hypoarousal symptom. So the hypoarousal symptom needs to be managed.
Dr. Majid has joined us from Srinagar. So he wanted to give a comment. Dr. Majid?
Dr. Majid,
Yeah.
please go on.
Then
Yeah. Thank you very much for giving me opportunity. And ma'am, it was really an inspiring lecture. Learned a lot from you. And as Aleem said, that we need to have more sessions, not only second, but I think more and more sessions. Keeping in view what Dr. Prasad Rao sir said, and I'll continue with that transgenerational trauma. I was a child of 17 years old in school once the turmoil started in Kashmir. I have been witness to siege in 94. It was for 4 months and it was locked down for 4 months. Our MBBS first year exams got delayed by 6 months almost. Then subsequently in 96, there was a counterinsurgent group and there was infighting and a lot of people got killed. And 2008, every one of us knows, our generation knows, we had lockdown for 6 months. 2010, almost 6 months, 2012 and 2016 and 2019, and now it is COVID. So in continuation, that is what probably for me transgenerational means. I was a kid once I started having lockdowns in 90s, early 90s, and I'm almost getting old and I'm just 15 years away from my retirement, and my child is around 16, 17. So he's seeing the same scenario on the road. There's a bloodshed. It doesn't matter. I'm a psychiatrist. I'm not a socio-political analyst, and I will not comment on, because the people are dying on both sides of the line. It doesn't, for me, it matters, life is lost. So for us, COVID lockdown or quarantine itself was not a challenge at all in Kashmir. That's my experience. I've started practicing for the last 2 months now. It's not a challenge at all, because we keep on hoarding things and we keep on hoarding medicines for our elderlies or for those who are sick. But what has been a worrying thing for me as a psychiatrist is the stigma attached to COVID, one. Second is the undignified death. Third is the undignified burial. And fourth is, unfortunately, the incomplete grief. The four important things which I have seen and experienced as a psychiatrist. So the stigma that is there, we need to probably work more on it. The mode of death, even the corpus are being seen as the virus reservoirs, and they are being, in fact, in Kashmir also, I saw a story from Chennai, a doctor who died and he was denied burial and his friend had to run from pillar to post to bury him. And secondly, in Kashmir also there are instances, although we have a very strong social and religious network, but still there are instances that people normally they don't allow them to bury in their nearest graveyards. And the way they have died, I lost my teachers wife during this period. She was like my mother, and I could not attend her burial, namaz-e-janaza we call it, and it will always haunt me. So the burial and the grief reaction, we normally stay together, relatives come, friends come and soothe and give an emotional sort of a support to people. That is lost. And sitting besides a dying person and helping him out, going to washroom, the person has not experienced that. It's a terrible, terrible scenario, let me tell you. Our hospital is a COVID hospital with more than almost till date we have treated 1,000 patients, and right now we are having 150 patients admitted. So I think the four important things: the stigma, the death, the undignified death, I would mean, the burial process that was not normal during this stage, and the grief of the people. I think we need to move forward and look for ways so that we can have a collective grief or re-grief, what is called. Yes. You may throw a light on that. Re-grief, I have not honestly understood what re-grief as collective grief means. Can you please throw a light on that?
Sure, I will try, sir. And I'm both sorry to hear the experiences that you spoke of in this part of the country, and also I feel that there must be so much of resilience that defines the people in your land, where so much has been going on. So I see it as the brain in that threat mode for so long that COVID does not feel any new phenomenon as such. As far as the grief is concerned, we are going through global grief right now. And we are also dissociating from that. We are also dissociating from realizing the level of grief, the degree of grief that we are going through. When we read, like you said, that it kind of dehumanizes the idea of death. It sort of no longer has that sense of loss. So we are only looking at morbidity figures as dehumanized. So like you said, that whole sense of loss of dignity of human life, loss of respect for human life, that itself can be traumatizing enough. And to add to that, we are also going through extreme loss events of near and dear ones. And not only that, of public figures as well. And that's acting like almost, not only people we know, so that's a lot of vicarious traumatization or secondary trauma. And we are also going through what I said, global grief that is going on. And this is something which is an extremely challenging situation for mental health professionals, because we are dealing with grief not just of a few people, but we are dealing with grief of communities. We are dealing with grief of geographically separated communities, and we can't even reach there in person. We can't even have that in-person connect of a therapist and the client. How do we deal with this? Is teletherapy enough? And these are questions that trauma therapists and mental health professionals are trying our best to understand and unravel the mysteries of the trauma that is impacting. I don't have clear-cut answers of what can help, but what I can share some of the rituals or some of the ideas of trauma therapists like Bessel van der Kolk, and they have done excellent work in the field of trauma therapy. One of the what should I say, groundbreaking work that has been done in the field of trauma therapy are by psychiatrists like Bessel van der Kolk and Dan Siegel. Bessel van der Kolk talks about how we need to bring communities together using technology. So he actually points out that we need to sort of exploit the whole video conferencing modality. He says that we need to make more face-to-face connections via video conferencing. We need to bring communities together even though we are not physically together. We cannot let the social fabric fall apart. We need to invest in that. We need to have rituals which bring communities together. If that be community music, if that be any kind of rituals which bring communities together as a family or as communities to just connect over video calls, we do that. So that's not my opinion, but that's something that Bessel van der Kolk has been suggesting, and it has been working. So probably as mental health professionals, we need to explore these kind of avenues. This is such a challenging situation that no one has got a template of what's going to work. We can only work with the best guesses that we have. As far as the concept of re-grieving is concerned, although I'm not a grief therapist, I know that people are specialized in grief therapy as well. But what I can understand is probably it's about bringing people together and going through that whole process of reprocessing the grief, allowing the space to reprocess the grief, so that we have not only the space, the safe space to process it, allow it to come out and give it the due respect, but also to actually have each other And that sense of dyadic regulation, the sense of having another human being when we are trying to regulate our brains, is crucial in trauma therapy and in grief work as well. It cannot be done, mostly it cannot be done over teletherapy, so which is what the biggest challenge is right now. I hope I was able to answer some parts of your questions at least, and I really appreciate you bringing in this, your personal example to help us understand and navigate through this transgenerational trauma.
Very well explained, Sukanya. One small question. Suppose I'm accepting all my trauma. So is this total acceptance same thing as what you do in trauma therapy, or what? There is a comparison, difference? What is the thing?
I would say that's a very good question, sir, because, you know, this whole idea of acceptance, that's not a nomenclature that is used in trauma therapy. We do call it reprocessing, we do say reintegration, but we don't call it acceptance. The idea is that it's not about accepting what happened to me. It's more about, if I can use a metaphor, about how I can grow through it. So the idea is not about, you know, okay, this happened to me and, you know, I'm going to move on with it. But how did it contribute to my growth? How did it contribute to my resilience? Trauma therapy works on that. It is that aspect of strengthening the self in, you know, what kind of self-growth can happen. If it not had happened in the past, it can happen now in the therapeutic context. And that is the trauma therapist's role. Acknowledging and enabling the client to grow through that process.
Yeah, so any sort of persons who are more suitable for trauma therapy, some persons who are less suitable, is it like that?
Yes, so there are contraindications, of course, and we cannot, we cannot do away with the contraindications. And many a times, trauma therapy can even get diluted if we don't understand those contraindications. The first contraindication in trauma therapy is the ability to regulate. If the client has very poor abilities to regulate or does not have the support system to co-regulate them as well, then probably our client is not suitable for trauma therapy at this moment. Maybe we can work on the regulation a little bit. Maybe we can get them to a safe space where they can build that. And like I said, that, you know, where all other trauma therapies fail, that's where neurofeedback comes in, because neurofeedback directly trains the brain to regulate itself. So there can be clients where that sense of self was never established because of early attachment ruptures, because of poverty, because of neglect experiences very early on in childhood. And with that kind of a dysregulated brain, where no other therapies seem to work, where we see what we see in, you know, severe conduct disorders, what we see in evolving antisocial personality or evolving cluster B traits, where we see a lot of dysregulation, where even the dysregulation is not controllable with medications as well. So that is when neurofeedback is you know, showing as a very promising approach to directly train the brain. So we need to be able to navigate that in terms of who's kind of amenable for therapy. We also need to know that, you know, in many of these therapies, because I said there are a variety of modalities of trauma therapy. Some of these therapies also have a very sophisticated language. For example, the PATHS work that I talked about. So unless our client is psychologically sophisticated enough to navigate through that language, ye PATHS kya hota hai? What is this PATH concept? This, you know, many a times clients might say, no, I don't have multiple personality disorder. So we need to be really careful when we are using that language. If we see that our clients don't have that capacity to process that kind of language, they may not be suitable for a particular approach, but they may be suitable for another approach. For example, a lot of a lot of our work with clients from the marginalized communities take concepts of narrative therapy. A lot of body work, perhaps. A lot of our clients where we see, we cannot use any kind of talk therapy because they don't have that language. Probably they don't even have that interoceptive ability. That what am I feeling inside? What is my body feeling like? So that's where body work can be useful. Psychodrama or theater or any kind of, enacting, embodied kind of therapy might be useful. So there's such a vast scope of trauma therapy. It would be wrong to say that any of these approaches wouldn't work for an individual. We need to sort of understand how to tailor make it. Where will the individual fit? What kind of criteria are there? So each of these therapies have their own set of criteria for fit, and we need to sort of be able to analyze that.
A few brief questions. After that, Amrit will take over. where do we get, what is the licensing procedure? Any separate licensing procedure is there for practicing trauma therapy, or any clinical psychologist can do that? What are the books and resources one should go after?
Sure. There are a few books and resources which I can pass on. I can send the resources, and those are of course open source resources. So if I just send the link, that should be useful. Of course, I can send a list of those resources. As far as the certifications are concerned, many of these specialized trainings are available for professionals, so people who have a license. And because many of these therapeutic modalities require a licensed, a license. So basically your registration in their platform would require that, without which they will not probably even consider someone to be eligible for the training. So there's an eligibility criteria for that. As far as the certification goes, many of these therapies have a stipulated number of training hours, a stipulated number of consultation hours, which are basically supervision hours, which need to be completed before they can sort of come out with that certification. And these therapies are quite well regulated. There are associations, worldwide associations, which govern their practice. So of course there is strict regulation in terms of practice and certification as well.
Madam, thank you. Just one question which we all wanted to ask. So
I shall ask a question. May I ask a question, moderator?
Sir, please.
So, Sukanya, personal compliments, a wonderful lecture. But what I understand, this involves a lot many therapies together, lot many approaches, and the patients are quite variable. The basic question, even if you understand the gravity of it, how to incorporate it in day-to-day practice?
Sure, sure. Thank you for asking that question. So I think that's a very relevant question. So even if I can sort of simplify it, even if we are not yet trained in trauma-focused therapy, even if we cannot do that, we can still do trauma-informed therapy. So which is where we try and understand the conceptualization of the client. We try to prevent any kind of re-traumatization from happening, and we know when to refer that client to, because stabilization is something which any clinician can do. We don't need certification for stabilization techniques. So if we develop a skill base of stabilization techniques, we can definitely use them to stabilize our client. But at the reprocessing bit, that is where I think we need to have that sense of competence and integrity as well, in terms of not doing the client any harm. So when we know that reprocessing is required, and if we don't have the qualifications, then we would pass it on to a trauma therapist who's trained enough. But till that, for stabilization, for basic work with the client, if you have a good rapport, if you have that therapeutic alliance with your client, we can definitely go ahead and do the stabilization techniques with the client. Many a times, the client may not even come back after the stabilization work. And that's because, what I talked about, that trauma therapy is about stabilization, stabilization, and stabilization. So if you have been able to do that role of, just stabilizing the client, the brain takes over. The brain has its own adaptive response. And then the brain has its own power to heal the trauma as well. So that's why it's important to be able to do the trauma-informed approach with the hours, the 5 hours that we talked about, and also know about stabilization techniques. So stabilization techniques are things that we've already done, and some of the reading resources that I can pass on also talk about them. So we can definitely use them in our clinical work.
Another simple question: post-traumatic phases, perceived stress or real trauma, whatever it is, we find most of the symptoms are gastrointestinal symptoms, GI symptoms.
Yes.
Does the gut-brain has to do anything with that?
Yes, absolutely, spot on. Because we have we talked about the somatic self, and that's where we know that parts of the insula actually store that sense of the interoceptive abilities. The insula actually acts like an internal map. So definitely there are very lot of literature to suggest that trauma does not sort of exhibit in terms of psychological symptoms alone, but also in purely somatic symptoms. So which is why the presentations of somatic disorders, somatoform disorders have been taken up with the trauma lens. And that's the whole idea. If I can suggest the book by Bessel van der Kolk, Body Keeps the Score, excellent book to actually outline this idea that how the body really bears the trauma and holds the trauma without the mind, sort of bringing it to its conscious awareness every day. So these are, very interesting insights into the mind-body connection as well. And like you said, the gut-brain connection. And we are only starting to unravel it, perhaps. Thank you so much for the question, sir.
So the last question is, 3 or 4 people have been discussing it, so I thought that, and you should be brief with it. Sure. History of psychotic breakdown. Does it deregulate the ability to undergo trauma-focused psychotherapy?
So some of the trauma-focused approaches do work with people with psychosis also. But of course, it requires very intensive levels of training. It is a kind of paths work that is done, but it requires intensive training to be able to do that with such symptomatic clients. So I've been brief in the answer. Yeah.
Thank you so much, because we have already crossed our time limit.
Yeah, I think, and everyone
Alim has to cook dinner tonight. So, Dr. Gautam, will you give me your last comments, or?
Gautam has left.
Yeah, Gautam sir, unmute yourself and please don't fly.
It was an excellent presentation. I have already written one of the best presentations I have attended in the recent past. Thank you, Dr. Sukarna. It's a really great. And what I asked also, there is acute trauma and definitely some chronic trauma. I mean, repeated trauma is there. I think there must be a presentation and management issues are different in those cases. I don't know in detail. If you throw some lights on it.
Sukanya, I think as I wish, and I am sure both Tufan, Alim and Amrut are thinking loud, we request you that you would come back to us with a definite model of how to do the therapy. One,
yes.
A few cases. And I personally have learned quite a lot in your session. And I really love the way you connected the neurobiology to these trauma therapies.
Definitely, we're thinking of that. We'll think of the modality and we'll fix it at some Thursday.
And Tupan called me for that session. I'll be there.
Thank you so much. Sir, may I hand over the stage to our president, Dr. Sujit Sahu?
Finally to the president. Yes.
Sir, Sujit sir? You are online, sir.
Okay. Thank you, Amit. As the President of IPS Odisha State Bank, I would like to thank all of our active participating members of IPS, and I would like to thank also Amit and Alim. So more than 210 participants are there. So this is one of this biggest webinar, and special thanks to chairpersons Professor P.K. Dalal, our IPS president, and also past president Dr. G. Prasad Rao to spare this evening to make this webinar successful. Then I must thank Sukarna Rai for presenting an excellent topic during this COVID time. And this is unexpected trauma, and this trauma is affecting all of our people. So this is affecting from laborer to doctor and from engineer to IT professionals, and all the peoples are being affected. But the thing is that people are those affected and they are serving. They are being named as Corona warrior, but different types of loss giving to trauma. What is Majid already pointed out, the different types of loss giving different types of trauma to the people, and hopefully this vital topic will be very much covering up for boosting of all our psychiatrists and clinical psychologists. But thing is that my request is then we'll go for another 2-3 more sessions to actually more slightly elaborate, because very much required. And I must thank attending all the people for the webinar. And my more important thing is that my mentor, Professor Dr. Tufan Pati, for his painstaking for tasks to make it successful. Then next, I will over this mic to Dr. Subhendu Mishra, Secretary IPS Odisha State Branch, for vote of thanks.
Thank you, Sujit sir. On behalf of Indian Psychiatric Society Odisha State Branch, I convey my regards and excellent talk for Sukanya ma'am regarding the trauma focused therapy. Our esteemed President of Indian Psychiatric Society, Dr. P.K. Dalal, for inaugurating the session. Our past President of Indian Psychiatric Society, IPS Dr. G. Prasad Rao, for moderating the session. Our State President, Dr. Sujit Sahu, for concluding the session. And the organizing chairman of this event, Dr. Tofan Patti. And I would say thank you to our organizing secretary, Dr. Amrit Pardeshi or Dr. Alim Siddiqui, for the excellent of these musings. Thank you all and good night from this side.
Thank you. Thank you so much.
Thank you to Torrent.
Good night.
Thank you, Torrent.
Good night.
Dalal sir, good night, sir. Thank you, sir.
Good night, everyone.
Prasad Rao sir, good night, sir.
everybody.
Sukanya,
Good
thank you.
night.
Beautiful.
Good night. Good
Gautam
night.
da, आप उड़ रहे हैं.
Thank you. Good
Superb.
night.
Superb.
Hey, bye-bye.
Gautam Dada, bye bye.
Bye bye, Gautam Dada.
अरे गौतम चला गया क्या?
हाँ,
चला
भाई.
गया.
नहीं
नहीं.
Gautam Da hai.
Majid, Dr. Majid, you are there?
Majid bhai.
Sir left.
Yeah, yes.
Majid bhai
Sir.
left.
Yeah.
अच्छा,
But
Dr.
Tufan,
Pinto is
it's a great meeting. Great meeting.
Dr. Pinto.
Doctor,
Absolutely superb.
ठीक था सर,
Dr.
ठीक था.
Pinto, he is,
ठीक था सर.
Pinto was there. He had kept my request and he had been here.
Vatve sir, thank you.
What sir?
Matuse is there. Yes, sir. Thank you.
Thank
ओपी
you.
सर पे
What
कहाँ चले गए? ओपी सर को मैं खोजा फिर चले गए.
OP sir
सब
was
लोग
there.
Superb presentation. Really enjoyed. Thoroughly.
गौतम दा, आपका पीछे जो वर्चुअल स्क्रीन है वो वहाँ पे आपका बाल उड़ रहा है.
हाँ.
वो होता है.
मैंने तो ठीक है.
Thank you all. Thank you all.
Thank you, sir.
सुवेंदु ऐसे ही होता.
Matuse is there, sir. Dr. M.R. Jha, sir.
Thank you.
Dr. Jawar,
Sir,
Jawar sir आए.
Sir, Bhai Sahab, thank you
Thank
very much.
Thank
Jawar Sahab,
हाँ साहब.
thank you very much. आप थोड़ा वीडियो ऑन कीजिए, हम आपको प्रणाम कर लेते हैं. हाँ. अरे बेनू हाउर
Jawar sir आ गए.
Jawar sir आ
Jawar आ
गए.
गए. नमस्ते.
सर म्यूट हो गया है.
सर अनम्यूट.
जावर सर अपने आप को अनम्यूट कर दीजिए. माइक ऑफ है आपका.
और अलीम तू अपने आप को म्यूट कर दे.
भवन स्पीकर मोड में ले लो सर को. भवन सर को.
Alim.
सर भौंक रहा था बीच बीच में.
अलीम
टॉप
भाई.
चल रहा भौंक रहा.
सर
टॉप चल
दादा
रहा भौंक रहा.
हाँ क्या हुआ? तेरा इतना उदास लग रहा है क्या? क्यों?
बीवी.
स्टाइल चेंज हो गया है.
हेलो अलीम भाई.
सर स्टाइल चेंज हो गया है अभी.
मेकअप सेंटर बंद है ना, अलीम भाई नहीं जा पा रहे.
कितने दिन चलेगा?
देखते हैं सर.
हम लोग जाएंगे नेक्स्ट मीटिंग में भुवनेश्वर जाएंगे.
आइए सर.
ऑनलाइन
जाओ.
अच्छा नहीं लग रहा है ज्यादा.
अरे अभी आ जाओ. You come here, there will be 15-day quarantine. Will arrange for you, no problem.
In a 5-star hotel.
Boss, I take your leave.
Sir, thank you so much, sir.
We'll talk
हाँ,
later.
ठीक है,
sir.
नमस्ते.
Okay, bye bye. Good night. Good
Sir,
night.
sir, it was okay, sir.
Hello, Vatve sir.
चलिए.
Okay, boss. Bye bye. Good night, Amrit boss.
Bye bye. Amrit, Alim, great going.
Thank you, sir.
Good night, Dada.
Good night, sir.
Good night. So,
Archana is the only beautiful face we see now.
Sir.
Hi, Archana.
Hello, sir.
सर हमको ऐसे कभी हाय बोल दीजिए, हम खुश हो जाएंगे.
Amrit, घर जा. Sara. Good night.
Bye bye.
Good night, good night, sir.
Good night.
Bye-bye.
Pawan, thank you.
Thank you, sir.
Thank you,
It was
sir.
nice.
Thank you.
Well done, Pawan.
Thank you, sir.
Tufan sir,
Well done.
Tufan sir, thank you to you.
Sir,
Thank you very much.
चलिए. Good night.
Good night. Right, sir.
मैं लीव कर रहा हूँ मीटिंग. बाय.